Hi, Doc.
Hi.
Um, so with a BP of 146/92, I would like to know the booking BPs.
They were normal.
How many weeks are they again? Sorry.
They're 32 weeks. The booking blood pressures were 132/80, and they were normal throughout the pregnancy.
Okay, so I think first, I would admit the patient, and then I would admit the patient for monitoring, and then start them on antihypertensives. Yeah, and then prepare for delivery while they are admitted.
Nicolene,
Um, so this blood pressure of 146, I would admit the patient as well and start them on methyl dopa, 500 milligrams.
continue.
Okay, and then maybe review the blood pressures. So if the patient is stable, I'm gonna then take a thorough history. And then plan delivery if the blood pressures are not controlled.
Tebogo,
Yes, doctor. So this patient is coming in with a BP of 146/92 at ANC. I would like to repeat the blood pressure after 4 hours. And if it is
excellent.
still high, then I would start the patient on a methyl dopa. But I guess before I do that, assuming that they are stable as well, I'll take their full history as well as carry out an examination. Oh, apologies, doctor. It seems like it muted. Um, I'm not sure where it stopped, but yes, after I repeat this patient's blood pressure, assuming that they are still stable, I would take their history and full examination at the antenatal clinic, as well as their urine dipstick and also PET bloods. And then I would start them on methyl dopa, 500 milligrams TDS.
Continue.
Okay, and then I guess maybe I would also admit them to monitor the blood pressure to see if it's controlled, to see if maybe we need to increase or reduce the dosage of the methyl dopa depending on the patient's blood pressure. And because they are still at 30 weeks gestation, I believe that they can still be seen as an outpatient.
That was good. What's missing?
To review the patient's investigations as well. So if the PET bloods come back to see if there are any features of end organ damage.
What is
I think
diagnostic of preeclampsia in this patient? What would be diagnostic of a preeclampsia in this patient?
if they have any features of end organ damage. So on the PET panel of bloods, this could come in the form of the patient having an elevated creatinine, And then also maybe if we do the urine PCR for this patient, and then it comes back with a value that is greater than 0.03, or while they are still admitted, if it's for more than 24 hours, we take the full 24-hour, we take their 24-hour urine protein as well. And then they could also have a deterioration in their liver function, and that would be evidenced by an increase in the levels of AST, if I'm not mistaken, past 70. And they could also have as features of preeclampsia on investigation on their, I guess that there's a complication of preeclampsia as well, but they could also have low platelets. But those are the things that are coming to mind now, Doc.
Mahlatse? I'm listening.
I'm continuing from the features of preeclampsia.
Mm.
Okay, so we'd look at the urine dipstick. So if the patient had proteinuria in the urine dipstick, or if the urine PCR comes back with a protein of greater than 0.3, and elevated AST enzymes that are greater than 70, LDH that is greater than 600, a thrombocytopenia that is less than 150.
Excellent.
And a urine creatinine that is greater than 90 millimoles per liter, as well as
No.
yeah, those are the ones I can remember.
Now the question then I need to ask actually, Mahlatse, should I not
Yes,
continue and sleep because I'm exhausted? Given the answers that I'm now given after speaking for 3 hours and 30 minutes on hypertension.
you can continue, Doc.
Continue to
Ask
sleep.
questions. No, you can continue asking questions.
Because now I'm just shocked. Diale?
Okay, Doc.
Should I not continue
Well,
sleeping?
No, Doc.
Hearing how disappointing the answers are.
Ish. Yeah, but
I think perhaps you guys must just think about how serious you must take my time. And then
we do take it seriously, Doc.
we'll reconvene some other time. I think perhaps we should postpone this and then you guys can think about how serious you need to take my time. Baloy? Nicolene?
Yes, Doc.
Were you not part of the tutorial?
I wasn't part of the first tutorial because I was
Why?
driving back home on that Sunday, so I missed out.
Nicolene, were you not part of the tutorial?
I was part of the tutorial, Doc.
Then what's happening? Tebogo?
Yes, Doctor.
What's happening?
Ish.
Maybe you all
We
must go
can
revise your hypertension and get back to me. I think we can adjourn this tutorial. Are there any things that you would like to say before I close the meeting?
Can you try again, Doctor?
Pertaining to try what exactly?
Or where we finished with the preeclampsia, the features.
Kind of, we can't start over because I spoke about hypertensive disorders for 3 hours, and I think I've covered everything. You guys shouldn't
Yes.
actually be surprised about any question that comes through. Mahlatsi, did I not cover hypertensive disorders? Did we not speak for 3 hours and 30 minutes?
You did, Doc.
So now, what is Teboho saying that I must continue? What is it that I should continue about? Because I believe I covered everything.
I think it's
retry the
referring to
question.
questions.
Because it's shocking for me to find out that this woman, one of you guys is saying that you are going to deliver. In the same woman, none of you is actually mentioning an abdominal exam, and none of you is actually mentioning an ultrasound. Are these not aspects that we covered in terms of the examination?
They are, doctor.
Moreover, you even forgot the preeclampsia panel of bloods. Let me think about this. If I don't log back, I'm not coming in. I'll send you guys individually a message to say I'm not coming in. This is a waste of time. It is a waste of time. Dube,
Hello, doc.
so the issue here is that when I teach, as I proceed to the next tutorial, I will then ask questions pertaining to the previous tutorial that I've covered. And if I get a situation where I actually feel like my time has been wasted, I will log out and then remove myself from this promise I've made to actually offer tutorials. Do you understand, Dube?
Yes, I understand.
Fifth years, you need to do better, because I can't give 3 hours and 30 minutes of my time on a Saturday talking about hypertensive disorders while you guys are actually the hypertensive unit. And then I'm hearing things like at 32 weeks, one is going to deliver a blood pressure of 146/92. At 32 weeks, I'm just failing to understand. Chauke, where are you?
Yes, Doc, I'm here, Doc.
Are you hearing these things that I'm hearing?
I joined a little bit late, Doc. I didn't hear the scenario.
You literally saved your ears, because what I was hearing here is just shocking. Now to HIV in pregnancy. I want you all to give me a glimpse of what you know or what you have covered pertaining HIV in pregnancy. You can raise your hand, anyone who wants to say something. Anyone wants to say something? Ndwandwe?
Hello, Doc. I'm not sure if I'm audible.
You are?
Yes, Doc. Even though it's we were on call by the time the tutorial was happening, but what was covered with regards to HIV was that it's one of the most common causes of the maternal. It's listed within the top 5 causes of the maternal death. So it's something that they always stress about, for which when a patient is coming in at a first visit, we usually love to test them because it impacts a lot on the management of the baby as well as the mother. So I'm not sure if yes.
Okay, yes, that's true. HIV related infections, actually. So it's non-pregnancy related infections that actually are the number 1 cause of maternal death in South Africa. So it's very important that one actually tries to combat HIV, because non-pregnancy related infections, based on the maternal, or rather the Saving Mothers and Babies report, that was actually released in February 2024. Yes, it was February 2024, where they were actually now reporting the deaths that occurred within the past 3 years. So with that being said, actually it was 2023, they were reporting on those deaths that occurred between 2020, 2021, and 2022. With the advent of the fact that there was COVID at the time, COVID was also added to non-pregnancy related infections, but moreover, TB also was actually part of it, as one of the causes of maternal death. So not controlling your RVD and suppressing the viral load may lead to detrimental infections of the mother that will then deem the mother as someone who has a high morbidity, that will then lead to such things. So it comes off as maybe puerperal sepsis, it may come off as a meningitis, it may come off also as a patient with TB. So it's very important. So with this lecture, I've actually incorporated a real case scenario that we dealt with in Unit 4. Then we're actually going to dissect the HIV latest guidelines that were released in August 2023, with some changes in some of those parameters, because these are now different from the guidelines that existed in 2021 and also 2022. So these 2023 guidelines were actually led by studies that looked at how to reduce non-pregnancy related infections as the number 1 cause. So now they are actually, or they were rather being active in actually trying to discover how to actually reduce these situations. So this case, important for you to actually follow from slide number 1 to slide number 22. It should actually take us briefly 30 minutes, where we actually discuss most of the things that need to apply to a pregnant woman. And of course, questions will arise from this case presentation as well, to actually reflect, and also just to check if you guys were actually capturing the essence of the case and the parameters that one needs to be very wary of when managing HIV in pregnancy. So it's a case presentation of an HIV in pregnancy that, as I said, continued in Unit 1, or happened in Unit 1. So this is a woman at booking on the 2nd of January 2025. So Miss SM is a 28-year-old para 1 graft 2 With the previous vaginal delivery at term with no complications, a male was born 3,500 grams in 2018, a medical history of RVD positive that was actually diagnosed in 2017. She actually defaulted treatment. Her RH was positive, HB was 11.3 with an RPR that was negative. On examination, she was found to have a blood pressure of 122/79, a weight of 68.3, height of 164.3, BMI of 28.3 kg per meter squared, MOAC of 28 centimeters, a systemic exam was NAD, CD4 count was 31 with a create of 38, a CLAT was done, which was negative, hepatitis B was negative with a viral load of 113,010. So an ultrasound was done on the same day and was determined to have an alive singleton at 14 weeks, 0 days, with an EDD of the 8th of July, 2022. Subsequently, remember her booking was at the local clinic on the 2nd, and she then, this is the timeline, she then reported at the same clinic, 18th of Feb, with a 20-week 0-day calculation via the early ultrasound. Height of fundus at the time was also 20 weeks with a BP of 130/78. And the weight was around 68 kg. In April, the BP then was 140/99. And at that time, she was 30 weeks and 1 day, height of fundus of 30 centimeters and 69 kg. Before that, there were not really any significant findings that were seen with the BP of 113/85 and a weight of 68.6 kg. On the 28th of May, she then reported to the same clinic with the BP of 156/97. Previously, it was 140/99. And then a month later, it was 156/97. And at the time, she was 34 weeks and 1 day. Height of fundus was 34 centimeters. Fetal heart rate was done, was determined to be 140/144. Protein was traced. The plan was to refer to George Mukhari. Same day at George Mukhari, or rather a week later at George Mukhari, 29-year-old para-1 graft 2 at 35 weeks, now diagnosed as a gestational hypertension at 31 weeks, at 31 centimeters on SFH. Ultrasound was done, a live singleton Catholic, and the BP at the time was 124/68. And at this time, the patient was already on antihypertensives with the diagnosis of gestational hypertension. So here, she was actually given methyl dopa at the time on arrival. A week later at George Mukhari, she was then seen, and the BP was around 124/68, and then PET bloods were done, and then she was then said to be reviewed or for review on the 24th of June. 24th of June, she came through, and at the time now, she's actually at 38 weeks, gestational hypertension at term. The blood pressure was 158/101, and the repeat was 131/101. Estimated fetal weight was 2658 with normal Dopplers, and she was admitted for BP control. And the plan there was to do induction of labor. Do we perhaps remember why do we do induction of labor at 38 weeks? Diale?
Okay, so we deliver at 38 weeks because beyond that, there is increased risk of severe preeclampsia.
You'd like to expand more?
Okay, can
Nicolene?
someone take it? Yes.
So Doc, I remember you said there was a study that was done, HIPPITED study.
Excellent. Excellent. Yes.
where they compared mothers that were hypertensive and those that were not hypertensive. And then they found that delivering at 38 weeks reduces the maternal morbidity and mortality.
So in this study, you are correct. In this study, they decided, it was a study, I think, that was done in the Netherlands, that actually looked at, do we intervene with induction of labor at 38 weeks versus allowing spontaneous delivery up until 40 weeks and 6 days? So they recruited people 18 years and older, and they said that let's actually admit patients who are around 36 weeks and above. And at 38 weeks, we are going to deliver via induction of labor. And then the other half of the group, we are just going to allow them to have a spontaneous delivery up until 40 weeks and 6 days, because they didn't want them to get to 41 weeks, which is post dates. So now they were looking at what is the difference between the two. Intervening at 38 weeks by induction of labor versus those whom we just wait and see until spontaneous labor actually occurs. And they actually found that those ones whom we waited for spontaneous labor to occur, those patients actually had BPs that were more than 160 over 110, and some of them even had affectations of the target organs. Some of them had HELLP syndrome, some of them had low platelets. So the maternal morbidity in those type of patients actually increased as compared to those whom they decided to actually intervene by induction of labor at 38 weeks. That's good, Nicolene. So with this particular patient, that then advises the management in George Mukhari why this patient was then admitted for BP control and also induction of labor. So on the 25th of Jan, adherence counseling was done because the concern was that the patient verbalizes that she does not have time to collect medication and often forgets. However, the repeat viral load was then done, and it was 84763 with a CD4 now of 13. The BP was well controlled and the PET bloods were within normal ranges. However, the urine PCR was 0.038. So on the 26th of June, then the following day, a gene expert was done, which was negative. And the patient was started on Refa-4 because of a urine lamb that was positive, and the patient was also started on Bactrim. So in labor ward, the patient remained in ward 25 and was induced with oral misoprostol. And she delivered a baby with an estimated fetal weight of 2835 on the 3rd of July and was transferred to postnatal ward. She was discussed with Sepang Clinic, which deals with HIV patients, and adherence counselors. And the delivery viral load actually was 1612. And the CD4 was 17 and a clad of that was negative. So the neonate was tested and was found to be RVD negative. So when you're looking at the 4 pillars in terms of the prevention of vertical transmission, we are talking about the 4 pillars in vertical transmission or prevention of vertical infections. We are looking at all the pillars as a whole. Most people talk about vertical transmission and they immediately jump to limiting the number of PVs for patients who are RVD positive, virally unsuppressed. But the prevention of vertical transmission actually doesn't start in labor, but it actually then starts even before the patient becomes pregnant, where the primary prevention is to actually look at reducing the number of HIV infections. That is, primary prevention is actually preventing transmittable diseases, especially among women of childbearing age. So in primary prevention, you speak about the use of condoms, and then also you also speak about using contraception as well. So putting the patient on an oral contraception or putting the patient on either an implant to prevent pregnancy, and also using a condom to actually prevent HIV. So prevention of vertical transmission is actually just talking about the prevention of mother to child transmission. So if you definitely prevent HIV, you are actually also preventing vertical transmission or the baby being HIV. But also in addition to that, you are preventing vertical transmission by actually preventing pregnancy to begin with. So if there's no pregnancy, there is no vertical transmission. No, again, if you prevent the advent of or the occurrence of HIV itself, then there isn't going to be vertical transmission at all, which is transmission of HIV from mother to child. So that's what Pillar 1 is actually talking about. Primary prevention, meaning preventing the actual occurrence of the disease to begin with, or preventing pregnancy. Then Pillar 2 now says, we are now preventing unintended pregnancy who have been diagnosed. So those who have been diagnosed with HIV, now we are preventing unintended pregnancies in those women. So preventing unintended pregnancies among those women diagnosed with these transmittable infections, which actually include HIV. So the first one is to prevent the occurrence of HIV, Pillar 1, or actually prevent pregnancy to prevent vertical transmission. But Pillar 2 now focuses on the mothers who are now diagnosed with HIV to actually prevent unintended pregnancies in that regard. Then Pillar 3 now focuses on all those things that students usually jump to. Now it's actually preventing vertical transmission from a woman living with transmittable infection to her infant. That now comes in to say when in labor, you avoid rupture of membranes, which is going to cover later. We are also going to avoid unnecessary PVs. So that's where Pillar 3 actually comes in. And then now Pillar 4 then focuses on providing appropriate care and treatment and support to women and their children and their partners. So now that the baby has been delivered, now that the baby has RVD is now RVD negative, is to actually avoid support, is to avoid treatment for the mother that has just delivered, but not only for the mother, but for the whole family, the women and their partners, their families, and their children. Is there anyone who wants to ask a question about the 4 pillars of prevention of vertical transmission? If you are hearing this question on the exam, it will the examiner is actually going to be impressed if you talk about the 4 pillars of prevention of vertical transmission. When they're talking about the prevention of vertical transmission, they are not necessarily talking about you are going to prevent unnecessary PV. Very important that you listen to the question that is being asked by the examiner. The examiner is going to ask prevention of vertical transmission in labor. Prevention of vertical transmission in labor. That's when you're going to jump to say all those things that we've just mentioned now. Unnecessary PVs, episiotomies, etc., which we're also going to cover later. But in this regard, it's very important that you listen to the question. But if they're saying prevention of vertical transmission, then that's when you actually talk about the 4 pillars. Do you understand, Ngoye Zulu?
Yes, Doctor, I understand.
Perfect. So now with that being said, let's proceed. Having this patient that we already discussed in the beginning, in the first 5 slides, to actually now look at what could have occurred or what we could have done. Looking at the first pillar, dual method is always recommended, which is a hormonal contraception, which also include implants, or an IUCD to prevent pregnancy. And then also a barrier method to augment the hormonal method to prevent STIs and HIV. So we have injectable progestins, combined oral contraceptives, intrauterine contraceptive device, or emergency contraception. So a dual method actually will start off by actually covering pillar 1 itself to say, actually, we are preventing not only pregnancy, but we are also preventing the transmission of HIV. So HIV testing now with the new guidelines should actually be done at each and every visit. Each and every visit, all the women will have an HIV test. That is 4 weekly intervals according to the basic ANC clients. So with that, you could do it at 20 weeks, 26 weeks, 30 weeks, 34 weeks. But because of the fact that we are high risk setting in George Mukhari, If you are going to see a patient for a review after a week because you want to see her PET bloods or you want to see her urine PCR that you've done, an HIV test should be done at every ANC visit. That is what is currently recommended at this current moment. So the CD4 management ladder is now, because of the fact that they've noticed there's an increased number, or actually TB infection or opportunistic infections that lead to non-pregnancy related infection. That is the #1 maternal death cause. According to the Saving Mothers and Babies report, they've then decided to modify some of those things. Previously, TPT, which is TB preventative therapy, was initially given at a CD4 count of 350 or below. However, now, with the fact that TB remains unabated based on their studies, they said, from now on, at any CD4 count, we are going to give the patients pyridoxine and also isoniazid. Isoniazid, 200 milligrams PO daily, pyridoxine, 25 milligrams PO daily to prevent TB. So now at any CD4 count, the new guideline says we will give them TB preventative therapy, which is isoniazid, 300 milligrams PO daily, accompanied by pyridoxine, 25 milligrams PO daily. However, now at a CD4 count of less than 200, now they are saying that now we are going to actually now look at prevention of opportunistic infections, which is historically known as PCP. Now it's called PJP. Anyone who's at a CD4 count of less than 200, that's when you can actually start Bactrim. At a CD4 count of less than 100, the lab will always do a serum clad cryptococcal antigen latex test. So now, with that being said, with the results that the patient actually had, serum clad was actually always done automatically, because this patient here had a CD4 count of 31. And CLAT was done automatically at the lab. So CLAT will always be done automatically at the lab when the CD4 count is less than 100. However, if a patient then tests positive, what you then do is you add an LP, and if the LP is positive, then you add fluconazole. You actually treat the patient as cryptococcal meningitis. Cryptococcal meningitis, there are more treatment modalities that you can use, but it depends if the patient is symptomatic or not. You can actually escalate it to more drugs that you probably have learned in internal medicine. I think one of them is amphotericin B, but now this patient is asymptomatic. Traditionally, you start off with that regimen of IV treatment or IV fluconazole. Then you taper off by giving fluconazole on a daily basis oral after you've given the standard regimen for cryptococcal meningitis. But however, this particular patient had a serum CLAT that is negative. It was positive. Then you add an LP. You then confirm if it is cryptococcal meningitis, and then you start off with the treatment, followed by an outpatient management of the oral fluconazole. CD4 count of less than 50, you must always stay alert because of unusual opportunistic infections or multiple opportunistic infections at once. Some guidelines do recommend a CD4 count of less than 200, but we're just going to stick with those that it's done. The cryptococcal antigen is done at a CD4 count of less than 100. It is done as standard in the lab without us actually even asking for it. So a patient who's newly diagnosed and initiated for antiretroviral treatment for the first time. So this patient comes in, 32-year-old para 1 graft 2. Now she's currently at 12 weeks. When you do a stat HIV test, you find that this patient is HIV positive. So what you then do is that you firstly do the first viral load at 3 months. If the patient does not have a history of being HIV, what you then do is that you repeat or you do the viral load after the patient has been on antiretroviral therapy at 3 months. So you don't diagnose HIV positivity in a patient who did not have HIV before and do the viral load immediately. Only patients who are newly diagnosed do you start them antiretroviral therapy, which is TLD, tenofovir, lamivudine, and dolutegravir. So you start that patient on TLD, but then you only do the viral load after 3 months. If the viral load is less than 50, that is a good viral load. It means that that patient is virally suppressed. Then what you then do is that you repeat the viral load at delivery, because what you want to understand now is how is the viral load at delivery so that you can actually risk stratify the individual in terms of the baby. That we're going to learn at a later stage. But if a patient is known with HIV positive when it's already with on ART, you actually do the viral load at first booking or at first visit at ANC. Now that is different from the one that I've just mentioned now. So if you get a positive HIV test, which is also evident what was done for our patient. She defaulted in 2017. She was known with HIV. That is why the viral load was actually done on booking. As much as there was a history of this patient not taking a medication or being a defaulter, you need to do a viral load when she actually comes, regardless of the fact that she was not taking medication at all. So those who are known to be HIV positive, those who are known to be HIV positive, who are not currently on ART, but are ART exposed, and you are initiating them on dolutegravir regimen, you must do the viral load after 3 months. Who are these people? These people are different from the ones that we've just mentioned above. This is a known HIV patient that was actually taking a different regimen that does not have dolutegravir. It could have been TEE, tenofovir, emtricitabine, and efavirenz. So these are the people that were now in the previous regimen. They can be virally suppressed, they can be virally unsuppressed. So, but now these are people who are not on the dolutegravir-based regimen and are known to be HIV positive. And then you then decide that you're going to start them on TLD. You will only then do the viral load at 3 months after you've initiated the dolutegravir to see where is she standing. If the viral load though is less than 50, which is a good viral load less than 50, meaning the patient is virally unsuppressed, then you repeat the viral load only at delivery. So testing for HIV, this is now after birth. You retest the HIV mother, the HIV negative mother, if she was not retested in labor. And then also again on their 10-week visit, 6 months visit, 18 months visit, when they're taking the baby for the INCI guideline-based protocol pertaining to vaccinations, you also extend by actually testing the mothers on their 10-week visit, 6 months visit, and every 3 months while the mother is actually breastfeeding, because you also want to know their viral status at that time. So this is now for just HIV negative mothers to actually prevent the infection of HIV by also now offering or continue giving them PrEP as needed, but also allowing them to also have the option of taking PrEP, but to also even put them on contraception and tell them about dual contraception as we had discussed before. So now, I've been mentioning a viral load that is less than 50 as a good viral load. Now, what happens then when the viral load is more than 50, which is then known as a viral load which is unsuppressed? So you always repeat that viral load every 4 to 6 weeks. And then you also make sure that the patient receives adherence counseling But also when you are doing that counseling, you need to also look at the ABCDE assessment of an elevated viral load, which will actually cover just now. So you must repeat the viral load after every 4 to 6 weeks while the patient is on treatment. And then if the repeat viral load is unsuppressed, you continue to reassess again and reassess again at 4 to 6 weeks to see if the viral load and the adherence counseling actually did work after exploring the ABCDE assessment of why could this elevated viral load be this way and why is it unabated by the TLD that you've been giving. So, however, viral loads or viral treatment failure pertaining to viral load, unfortunately, will not be something that could be assessed. Treatment failure is something that cannot be assessed through the pregnancy period, because treatment failure is when a patient has at least been on TLD for at least 2 years or two or more consecutive viral loads of more than 1,000. So now the extension of that is that the patient, for you to actually say, this TLD is actually not working, this patient should have been on TLD at least for 2 years. And then also, this patient at least showed at least more than 80% adherence in terms of their file. But what am I saying? Adherence of more than 80% is confirmed by, in the past 2 years, did the patient come fetch their treatment every 3 months? And then also documentation of their viral load through these visits. And then also, does the patient actually complete the treatment? When they come through, do they have evidence that they've completed the treatment? And then also, all their visits in terms of their follow-up visits, in terms of completing their treatment and fetching more treatment, 80%, more than 80% is then actually diagnosed as a patient who has visited at least more than 80% of the required time. What am I saying? If I'm saying to the patient that you are coming to collect your medication every 2 months, and we're going to document your visits. Every 2 months in a year, it's 6 visits. And the following year, every 2 months in a year, it's going to be 6 visits. So out of those 12 visits, has the patient at least attended more than 10 of their visits pertaining to collecting their medication? And that now I would say that patient is more than 80% adherent. And during that time, for at least 2 years, when we looked at the viral load and the CD4 count, they were actually showing that there's something going on. The CD4 count is dropping, but however, the viral load in terms of virological failure is the one, or treatment failure is the one that then diagnoses the patient as someone whom we need to consider changing the TLD, because it's no longer a wonder drug that they have actually investigated it to be. So during pregnancy, it becomes difficult to actually assess that, because you need to liaise with the treatment facility that has been giving this patient their TLD for you to actually confirm this patient is adherent for more than 80%. Does it make sense? Ramarumo?
It makes sense, Doctor.
Masingi, does it make sense?
It makes sense, Doctor.
So what you guys then need to know is that you need to just manage the viral load by actually giving adherence counseling and exploring the ABCDE. And also, in addition to that, looking at the viral load every 4 to 6 weeks to see where we are sitting with this patient. And the patient, remember, is only with you for only 9 months. What is this ABCDE that I'm actually talking about? Adherence. The medication poor? Does she take a medication every day? Or is she not taking it under the influence of medication side effects? Are there any other mental health disorders? Is this patient depressed? Is this patient having bipolar mood disorder? Is this patient also having an element of a mental health care issue? Is there an alcohol or substance use that the patient is actually even skipping the medication? Is there poor social support? Or in some other cases, some patients actually don't even tell their partners that they are RVD positive, so that they actually mask the issues that may actually come about as to, but why are you taking RVD, HIV medication, you know? So they hide it from their partner in that regard. Could it be because of the fact that they are taking other drugs for infections? Like, for example, they are taking TB medication, hence why they decided to stop their RVD medication. Is it because of the fact that they've been told to prevent IRIS, that, okay, let's hold on the HIV medication, let's reintroduce TB medication, and then let's start TB medication, or rather reintroduce TB medication on a later stage, or reintroduce RVD medication to actually prevent IRIS? Or is it because of the correct dose? Is that currently the patient on the correct dose of this current medication? And then also drug interactions, because anti-epileptics and also TB medication may also affect the uptake of drugs because of the cytochrome P450, either inhibition or activation, and also resistance. So you must consider drug resistance or virological failure to be excluded if the patient actually now, the viral load still remains more than 1,000, and you've proven that she's been on this treatment for more than 2 years. And in addition to that, the patient at least has maintained attendance of more than 80% in terms of the adherence parameter. So other things that you also need to know that may affect the dolutegravir uptake is the fact that calcium and also ferrous, if you have that without food, with your RVD medication, you get a decreased dolutegravir levels. So what they actually say, that if you are taking your calcium or if you're taking your ferrous with dolutegravir, you must have it with food, and then it will not have any effect. However, calcium and iron must actually be taken for 4 hours apart, with any other antacids, magnesium or aluminum, regardless of food. So they're saying that take the antacids 2 hours after, or 6 hours before you actually take the dolutegravir, because these drugs do interact with it. And also, with that being said, they may actually increase or decrease their the drug's bioavailability. So viral load monitoring. So all women must actually have a viral load that is actually done at delivery. And the intention of this is that the viral load is that you're not looking at also not only virological failure, that is something that is on the side, but however, virological viral load monitoring is important, because what you want to actually establish is, am I going to give the mother, or the baby, dual prophylaxis, which is nevirapine and also in AZT. So now, with that being said, if a mother's delivery viral load is not out, any mother who's RVD positive, regardless of the viral load, while still waiting for the viral load delivery results, you need to put the baby on nevirapine and AZT. The viral load may be checked within 3 to 6 days, and then the management of the infant mother pair will then be adjusted accordingly. So if the viral load is less than 50, you encourage good adherence, and then you repeat the viral load 6 monthly during breastfeeding. So if the viral load is less than 50, the delivery viral load is less than 50. Remember, I had mentioned before that then you risk stratify. Risk stratification applies to the infant. The infant then will be reclassified as low risk. Initially, RVD positive mother, we will then risk stratify the baby as high risk up until we get the delivery viral load. If the delivery viral load is good and it's less than 50, then the infant will then be classified as low risk. So the baby then, or the mother rather, the baby will then be on AZT and also nevirapine while waiting for that delivery viral load. So for all the pregnant women who are HIV positive, These are now the things that where you guys come in, where you guys excited, you become very excited to go there. When we're talking about prevention of mother-child transmission, we forget about pillar 1 and 2, then we jump to the things that we do in labor. However, these are the things that you then need to mention when you are talking about prevention of mother-to-child transmission during labor. That's how the question is going to come during labor. But prevention of mother-to-child transmission is the 4 pillars. So during labor, you avoid unnecessary episiotomies, you avoid unnecessary assisted delivery, unnecessary rupture of membranes, and excessive suctioning of the infant. If a C-section is required, prophylactic antibiotic, unless sepsis in the mother requires the use of therapeutic antibiotics. Encourage skin to skin and also breastfeeding. There was a question in the previous ward round where because of the fact that I had read my HIV guidelines, or I knew my HIV guidelines, one of the students final year from the previous group, I think 2 groups before, stood there and said they were doing a handover. And then they stood there and they said, formula feeding. And then Prof. Matsela was saying that, oh, so this mother is RVD positive, viral load unsuppressed. And I think the viral load at the time was around 121,000. The student then said that, no, the mother cannot breastfeed. And then I stood there and I said, the mother needs to breastfeed. And each and everyone in the ward round was asked one by one as to what do they think. Funny enough, most of them actually sided with the students to say, the mother cannot breastfeed this child because the viral load was around, as I said, I think it was around 121,000 somewhere there, but it was actually more than 110,000. So the students and the rest remained and said, no, not breastfeeding, because the baby will get the HIV through the breast milk. And I stood there and I said, no, the mother must continue breastfeeding. Why did I say the mother must continue breastfeeding? Any takers? I'm listening. Five more slides left. Abel, let's continue. I'm listening. Any takers as to why I said yes?
Doc, is it because of the low risk of transmission with breastfeeding?
No.
Doc, I'm also thinking that because we have said that if the viral load is more than 50, we're going to give the baby NVP and AZT. So if we're putting our baby on prophylactic, then we don't have to worry. And then
Excellent.
furthermore,
What else?
we have to furthermore counsel the mother and make sure that the mother's is taking adhere to medication as well.
Excellent. What else? But there was a very important factor, and it had to do with studies in pediatrics. Dwandwe? Yes, Nicolene?
If I remember very well, they said the formula messes up with the mucosa of the intestines of the baby. So should
you are warm, but most mothers do formula feed. You are getting somewhere, but you are not there yet.
Should I continue getting warmer?
You are, yes, continue.
Okay, so they said
I'm happy.
So they said if by any chance the baby is exposed to the mother's breast milk, they'll be infected because the lining of the mucosa would have been damaged by the formula.
You are getting warm, then cold. Siaya? You are warm, continue. Tabiso, very warm, continue. Expand more. It has to do with the feeding. Yes, continue. Mm-hmm. Yes, sir. Yes. Yes, yes, yes. Oh, Tabiso, I'm impressed. So, because we are actually in a low risk, or rather low socioeconomic status, we are dealing with mothers at a very low socioeconomic status. Mothers who are then told that the baby will be infected if you breastfeed the child. Most mothers then, because of that, some of them are even teenagers that are pregnant that were married at a very young age. You find that the fathers are working somewhere, somewhere in the mines or something of that sort. Mothers actually substitute this formula feeding with water and Cremora. Some of them actually even feed the babies cow's milk. So there's been an increase in terms of the babies that were actually admitted for severe acute malnutrition, leading to an increase in terms of the infant death. So that is the reason why I stood there alone to say breastfeeding, because the studies have revealed that most mothers, especially in low resource settings or low socioeconomic status, have actually, there's been a rise of severe acute malnutrition in those mothers who are found to be RVD positive, who then have been informed that they should not breastfeed. So most of these patients that actually come through with their babies during their first year of life, or even within the first 6 months, their main reason, all of them were found to be RVD positive, and the main reason for the patient being or for the baby being admitted is because they substituted the breast milk. They couldn't afford the formula milk. They would give the baby water. They would actually add water with Cremora or add cow's milk to actually feed the baby, which is actually something that is definitely wrong, because the GIT of the baby is not mature enough to actually handle those type of milks rather than the breast milk. Does it make sense, Nicolene, why you were warm?
Yes, Doc, it makes sense.
So, now back 4 more slides. So HIV, actually get a birth PCR, of which this baby did receive a birth PCR, and then dual prophylaxis of NVP and also AZT until the results of the viral load can be reviewed. If the viral load then is said to be less than 50, you reclassify the infant as low risk and you stop AZT, and then you continue NVP daily for about 6 weeks. But however, if the viral load is said to be more than 50, you reclassify now the baby as high risk, and you continue with AZT twice daily for 6 weeks, and you continue nevirapine daily for a minimum of 12 weeks. But NVP should actually, nevirapine should only be stopped when the breastfeeding mother has an HIV viral load of less than 50, or if the viral load is not less than 50, up until 4 weeks after she has stopped breastfeeding, which also adds to what was said as an answer to say we are actually protecting the baby by giving the baby nevirapine while the mother is actually breastfeeding. So regardless of the viral load, you can continue under the patients whose viral load is more than 50, then those mothers will not only continue nevirapine for only the 6 weeks that was recommended, but the nevirapine now will only be continued until 4 weeks after the mother has stopped breastfeeding. Do we understand that parameter pertaining to the viral load? Ramarumo, do you understand the AZT and nevirapine regimen?
Yes, I understand, Doc.
So if a patient's viral load at delivery is less than 50, you will then give the nevirapine, and then you stop the AZT. If the viral load is more than 50, that baby is high risk. You continue AZT for 6 weeks and you continue nevirapine for a minimum of 12 weeks. If that mother is saying that I'm going to continue breastfeeding, you continue that nevirapine, protecting that baby up until 4 weeks after she has stopped breastfeeding. So again, when the mother has delivered with the viral load of more than 50, you then continue with adherence counseling, and then you need to readjust the nevirapine doses according to weight. So as the baby grows and gains weight, you adjust the nevirapine doses as per PEDS protocol. And then high-risk infants, you actually stop the AZT but continue nevirapine for a minimum of 12 weeks up until the viral load is suppressed. Once the viral load is suppressed, then you reclassify the baby as low risk. There's no need for you to continue with the nevirapine now after 12 weeks. But if the mother now has a viral load on your recurrent visits postnatally, and you see that, okay, the delivery viral load was more than 50, but however, on her follow-up visit at 6 weeks or 10 weeks, you find that, the viral load is now less. There's no need for you to actually continue then with the nevirapine up until the mother stops breastfeeding. The baby then gets reclassified as less than 50, and then those patients, you stop the nevirapine after 12 weeks if the viral load is less than 50, but if it's not suppressed by 12 weeks, you continue the nevirapine up until you get a confirmatory viral load that is less than 50, or until 4 weeks after all breastfeeding has actually stopped. So if the child is HIV positive at any stage, then you stop the nevirapine and then you initiate antiretroviral treatment. We revision again in terms of the CD4 management ladder. As I said, now TB preventative treatment, you then give it at any CD4, and then you add Bactrim at a CD4 of less than 200 to prevent your opportunistic infections. At a CD4 count of less than 50, you actually stay alert for any opportunistic infections or multiple opportunistic infections. And then when it comes to TB treatment, you need to take a clinical exam, and then you actually need to screen for TB. The questions that you guys usually ask: any night sweats, any cough, etc., hemoptysis as well. And then if the patient now does actually have these symptoms, you then test for TB. During that time, you need to initiate the patient on ART the same day, while then you review the results of the other things that you actually do. If the TDF is contraindicated due to a history of suspected renal disease, you change the tenofovir now to abacavir. You review the results for the initiation of ART, but you do not delay the initiation of ART because of TDF and the fact that it's contraindicated if a patient has a creat of more than 85. So TLD will then be replaced by abacavir, lamivudine, and dolutegravir. So it will be replaced by ALD if your creat is more than 85, because your tenofovir actually interacts with the kidneys and will actually cause more renal impairment. But you do not delay the initiation of TLD while awaiting those results, but you can review the patient's results within 3 to 7 days. As I said, if the CD4 count on that patient is less than 100, then the cryptococcal antigen is going to be done. If it's positive, you refer the patient for LP, and then if it's negative, then you continue with the ART treatment. And then you review the CD4 count at a later stage. I think it's after 1 year. So if the patient now has TB symptoms, what do you then do? You do quickly a gene expert. If the gene expert is negative and there are no TB symptoms, you continue with ART. And then after that, you've noticed that you've diagnosed now that the patient has no RVD at all. But now, during the time while you are actually waiting for the gene expert results, if the TB diagnosis is confirmed, you initiate TB treatment first, and then you review the patient in 2 weeks. If stable and tolerating the TB treatment, you reinitiate the ART if not already initiated. So that line in brackets is actually now going to answer some of those questions to say, Dr. Mavata, I've screened the patient for TB, and the patient now has reported that they have weight loss, they have hemoptysis, and also again they have night sweats. So now, as I said, you initiate the TB treatment, the RVD treatment the same day while awaiting your gene expert results. If the patient was not already initiated because of that screening that you did, if you decided that, let me wait for the gene expert, you can hold on the initiation. However, if you already initiated the patient while waiting for the gene expert results, you stop then the TB treatment and then you reinitiate it after 2 weeks so that you don't actually get symptoms, you don't get a complication which is ARAS. How do you then actually see if the patient is ARAS? It's all the symptoms that they're actually talking about here. If a patient was on TB treatment and then you reinitiate RVD treatment, if a patient has a tachycardia of more than 100, a BP of less than 90/60, if a patient has hemoptysis or actually neck stiffness, visual disturbances, confusion, agitation, or is unable to walk unaided, that's when you actually think of the danger signs. So that is why doctors usually say do not start ART until TB has been excluded or diagnosed, as these may be at high risk of developing ARAS. Then they then add the symptoms, that is shortness of breath, difficulty breathing, respiratory rate of more than 30, temperature of more than 38. So at this current moment, when you've screened the patient for TB, and then you're like, this patient has tested positive for screening or has screened positive. Let me wait on the initiation of treatment. Let me exclude my TB. And then after that, what I'm going to do is, after I get my results, then that's when I'm going to reinitiate after 2 weeks. So let's go back to the case and critically analyze what we have learned and what did this unit actually miss out on. So I'm going to go slide per slide. I believe that you guys actually did listen to the case. But however, let me take a few questions and then I'm to ask a few questions as well to critically analyze the case to see what did this unit actually do wrong? Any questions so long? Yes, Tabiso? So during that time, you treat the mother still as an obstetric patient. You use pillar number 4, and you use the same practical things that you did when the mother was actually pregnant. So during that time, as much as the mother is out of puerperium, this also adds now to pillar number 4, where now if you've diagnosed that the mother has a viral load of more than 50 after the next visit, previous visit, the viral load was less than 50, you reinitiate nevirapine up until the viral load is actually less than 50, and you do recheck your viral load within 4 to 6 weeks. Does it make sense, Tabiso? So the birth PCR, there is a space for birth PCR to actually be done. There is no reason for you not to do it when you're looking at the viral load of the mother being now more than 50. This is now you are reclassifying the baby as a baby who is now high risk of getting what's this HIV, because the viral load is more than 50. There is a space for you to actually do a birth PCR at the time, but also still putting the baby on nevirapine. The birth PCR should be out within 3 days. And then now your treatment then changes from nevirapine, where you stop it and then you initiate the baby on HIV treatment. Does that answer your question, Thabiso? Okay, any other question? Now we can critically analyze the case to see where could the doctors actually missed out on this management of this patient. So we're going back to the case, knowing what we know now. SM was a 28-year-old, previous vaginal delivery. Medical history was that she was RVD positive, diagnosed in 2017, defaulted treatment. What the doctors actually did right here was to actually do a viral load, because they don't know where the woman is actually currently sitting. However, my question now will be the following. Patients who are known to be RVD positive, and in what situation are you not going to do a viral load on booking for a woman who is known RVD positive? When are you going to delay the viral load on the initial visit on booking? In which situation? Let me pick. More? Oh, actually, let me also add, I want to ask a question. Chauke?
Yes, doc.
So, is it fair for me not to be impressed if I'm not getting the answers after I've just taught? So it then therefore means that, is it fair for me to assess the performance of how you guys initially critically analyze the case with what I've just taught? And then if you guys are not doing well, it then therefore means that that compromises the next tutorial, which is APH and PPH. Is it a fair statement? Because if you guys are not doing well in terms of answering these questions, then I can defer tutorials until further notice. Is that a fair statement? Chauke?
Doc, I'm not sure.
Chauke, answer the question.
It's not fair, doc.
Ndwandwe, answer the question, because I'm not happy with Chauke's answer.
Am I audible, doc?
You are very audible.
Oh, doc, if you are not impressed, I think it depends on the degree of the severity of like the wrongness of the answer. But
okay, Thabiso, is it a fair thing to say? Okay, the first question then, I'm expecting a hand. In what situation would you defer a viral listing on the initial booking for a patient who's RVD positive and was known to be RVD positive? Yes.
Doctor, you said we only defer in those, we only do the viral load at 3 months in those patients who are non HIV positive and who are not currently on ART regimen, but you are initiating on the dolutegravir regimen.
Yes, excellent, Ngomezulu. You were listening. I'm impressed. You are doing extremely well. So you are actually saving the rest of the people who are not listening. But let's continue. I'm planning to become more intense in terms of asking these questions. Let's continue and see if everyone is going to answer. Thank you. Thank you. Wow. So we learned that this patient actually is RVD positive. So clearly this patient actually was on TLD and the patient was not on TEE or on the previous regimen where it was either the patient was on tenofovir, tricitabine or efavirenz. It's a different type of regimen. Thank you for that. You only defer once you start the patient now on TLD, and then you will review while the patient is on TLD. You're going to repeat the viral load after 3 months. Excellent for that answer. You were listening. This patient then did an ultrasound at 14 weeks and 0 days. Estimated date of delivery was the 8th of July. So now this is the timeline. Can someone actually comment on what happened between the 30th of April and the 28th of May? I'm listening. Heibo, any hands? Or maybe I must choose. Tebogo?
Yes, doctor. So between the 30th of April and the 28th of May, the patient had an increase in their blood pressure.
Okay.
Yes.
So the booking blood pressure of this patient was 129/79, and then
Yes.
the booking blood pressure was 122/79, and then later on the blood pressure was then 140/99. What do you then understand about the diagnosis of gestational hypertension?
What I understand about the diagnosis of gestational hypertension is that it is when a patient has a blood pressure of greater than 140/90, taken 2 times 4 hours apart after 20 weeks, or if they have an increase in their diastolic, in their systolic, I mean, that is greater than 25 millimeters mercury from the value that was there when they were initially booked, and then they also have an increase in their diastolic by 15 millimeters of mercury compared to their booking blood pressure.
So was this patient gestational hypertension at the time?
At the time, let me see. Can I refer to, can we go to the other slide, Doc? Okay, so it's 122/79. Then it went to 140. If the blood pressure was repeated and it's still 140/90, then I would say yes.
So looking at the 2 blood pressures, does the patient actually qualify to be gestational hypertension? From booking, which is 125, 122/79 over
Oh, yes.
79. Yes.
Yes,
So
they
the
do.
patient
Yes.
actually was gestational hypertension already because
Yes.
the diastolic actually increased by more than 15
50.
because
Yes, okay.
79 and going to 99, that's 20. So the diastolic is an increase in 15. So that
Yes.
assessment already here, the patient was supposed to be diagnosed as gestational hypertension. Because of the rise of the diastolic from 79 to 99. So that's already more than an increase of 15 milligrams of mercury. So that
Yes.
patient already, the clinic missed out on that. That patient was already a gestational hypertension and should have been initiated on treatment already on the 30th of April, and not for them to wait on the 28th of May to actually say that the patient is now gestational hypertension because of the 156/97. Patient was already gestational hypertension on the 30th of April based on that diagnosis that we've also added to say that it's not only 140/90 with 2 blood pressure repeats 4 hours apart, but also a systolic over 25/15 and a diastolic over 15 that will actually diagnose gestational hypertension in a woman. So there was a missed opportunity in the clinic.
Yes, doctor.
So on the 24th of June, This patient was a 29-year-old, para 1 graph 2 at 38 weeks, gestational hypertension at term, and the repeat blood pressure was 131/101. Estimated fetal weight normal, Dopplers admitted for BP control and IOM. And then on the 26th of June, 2 days later, the patient had a urine lamp positive, gene expect was negative. She was asymptomatic and was started on Refer-4 or Bactrim. Anyone who wants to critically analyze that management? Tabiso? You are very audible. I disagree. I disagree. It was 158. Yeah. Yeah. So there's nothing wrong with admitting the patient for BP control. But what I wanted you to analyze was the 26th of June. What do you want to say about the management of that patient? So now going back to the urine lamp, anyone who has a CD4 count of less than 200, you do a urine lamp according to the TB guidelines to diagnose TB. So if TB is confirmed either by gene expert or chest x-ray or sputum culture, that is when now you actually now diagnose TB with the urine lamp. But however, I'm listening. So your answer there is wrong. Why am I saying that? Ndwandwe? Masingi, why am I saying CII is wrong? Diale?
Doc, I think according to the slide, is that if the gene expert is it's negative and the patient is asymptomatic, so In this case, I don't think they were supposed to have started with Rifa 4. I don't know, because according to that chat that you gave us, that you showed on the slides, it indicates that if the patient, they have TB symptoms and we investigate, that's when we can confirm. However, in this case, I'm not sure if I'm on the right track even.
No.
Oh, okay.
Dube?
I'm not sure, doctor. I would have also agreed, because they say if a patient has, if they are severely immunocompromised, they may not have symptoms, so hence why she's probably asymptomatic, and even the gene expect might be negative, so a urine lamb is usually a good indicator that they have TB. And so I think I would have agreed. I don't know why he's wrong.
Hi, Dube. I think you must actually listen to that alarm. It's time to sleep. Don't you think so, Dube? Dube?
Yes, doctor.
Do you not think it's time to sleep? I think it's time to sleep. Dube?
Yes, doctor.
Should we not sleep, Mara? Because I'm not getting the answer. Maybe we should sleep now.
Maybe we need a bit more. Where exactly is he wrong? So maybe we can try and
We need to sleep, Dube. We need to sleep. Don't you think so?
maybe we can finish and then sleep.
And one way, are you also sleeping?
Yeah, the alarm rang to me as well, but yeah, I can try.
I think it's
try.
time to sleep now.
No, doc. No, doc. I think I was leaning more towards him, but I think the case of a gene expect that is negative is like I think in the case of a positive urine lamb alone, I don't think it's quite good enough to just confirm in this case it's the patient
One
is
can argue that. One can argue that to say that in a urine lamb is not really quite sensitive, but you do a urine lamb to those who are number one admitted, chronically ill looking, and then also in addition to that, you also do a urine lamb in those with a CD4 count of 200. This is now according to the to the TB guidelines. So if the TB guidelines are actually saying that the patient is actually positive, it was a bad decision for the doctors to actually start the TB treatment. Yes, you're supposed to reinitiate TB treatment, but you are supposed to stop your RVD treatment. You then reinitiate the RVD treatment after 2 weeks. I thought really discussed. Tabiso, is it not what we discussed? If the TB diagnosis is confirmed, you initiate TB treatment, and then if not already initiated, you initiate ART. So are we sleeping, Siaya? I think we are sleeping. Pardon? I'm thinking we are sleepy because I thought that answer was gonna come. Diale? Tebogo,
Yes, doctor.
are you not sleepy? Why didn't the answer come? Why didn't you raise your hand?
Ish, doc, I was a little unsure. The viral load scared me.
So the number one, let me just actually give you the critical points of this case because all of you are sleepy. delayed referral to the clinic for gestational hypertension, delay in starting antihypertensives. Also, the viral load was actually not monitored because it was supposed to be repeated within 4 to 6 weeks after adherence counseling was actually given. This patient's viral load was only done at delivery on the 25th of June when the patient was actually planned for IOL, where the repeat viral load was 84763. None of you actually were even curious about the viral load as this patient was actually doing monthly visits because the viral load was actually not done. The ANC just did routinely height of fundus, blood pressures, and also just did your normal blood pressures and SFH. And everything else, they actually disregarded the viral load, which needed to be repeated every 4 to 6 weeks, because we need to be actually having a viral load each and every month to see what are the trends. In addition to that, the doctors or the clinic did not start the patient on Bactrim or TB preventative treatment, because I would have mentioned that here to say patient was actually referred or initiated on that treatment. So TB preventative treatment was supposed to be started immediately because already the CD4 count was 31. Not only TB preventative treatment was supposed to be started, but also Bactrim was actually supposed to be started because the CD4 was less than 200. So what is happening? Do you think I was actually going to get those answers? Nicolene, do you think I was going to get those answers with all you sounding very sleepy?
Yes, doc.
You will get those answers from you guys?
Yes, doc.
How? Because those answers didn't come about. Actually never even came through. Ndwandwe?
Yes, doc. Doc, I think they were going to come. It's just that we had maybe, yes, they were going to come. But there is an element of maybe the sleepiness. But yes, we did grasp everything that you mentioned, doc. And now that you are telling us, we are actually getting more emphasis as to how to approach it in a real life settings, like to identify these small mistakes that happen.
Anything else, Tabiso? Chauke?
Yes, Doc, I'm starting some light. Starting to see some light, Doc, from the corrections that you've made. I think I was not following, but now there's light.
And so you were not following, and then now you are like?
There is light, Doc. I think now I understand. It was more of the way the question was asked, but now I'm following that. Okay, with less than 200 viral load. No, not viral load. The CD4 count.
Hey, Chauke, you are very sleepy.
Yes, I am exhausted, but you can continue.
Well, yeah, ne? And I know very well that this call was not busy. And people are very sleepy. Dube?
Yes, doctor.
Are you now fine with the management of HIV? Anyone who actually wants to ask a question, I'm listening. Okay. Now, with the fact that here there's silence, I think we can continue to the next one. Nicolene, can we continue with the next one? Or you are or you are sleeping?
We can continue.
Okay. Ngomezulu, should we continue?
Yes, Doctor, we can continue.
So now we hemorrhage. The aims of this tutorial is just to actually understand, to recognize obstetric hemorrhage, understand the causes of hemorrhage, and to actually just practice skills needed to respond to a woman who's bleeding, to actually achieve the competence, or to achieve competence in those skills. So you must understand that hemorrhage is actually the most common cause of maternal death worldwide. Now we are looking at the global stats, because remember, some other countries have found ways to actually mitigate the rise in HIV, making non-pregnancy related infections not necessarily the number one cause of maternal deaths in those countries. That is the first world countries. But however, in countries like South Africa, we actually have non-pregnancy related infections as the number one cause, because at this current moment, we haven't found ways to actually mitigate the rise in HIV. So actually in South Africa, it actually accounts for about 30% of the maternal deaths, as we had learned that the majority is non-pregnancy related infections. And then the deaths from hemorrhage actually could be avoided, because over 80% of hemorrhage deaths are actually avoidable. And looking at now the Saving Babies Mothers report, the number of maternal deaths, now this is actually corrected. It's corrected in the sense that it's looking at 2017 to about 2023, where you see that Gauteng was sitting at about 175 maternal deaths in the year of 2023. The corrected version is 217 actually. So let's look at this paragraph. So the corrected version is that all those files that were actually being reviewed, these results were actually released prior to that. So some of the files that were not reviewed prior to the actual release of these actual results. So corrected is when further investigation was done into more files to actually then learn that the number of maternal deaths per province in 2023 now rose to about 217. So if you look at the trends, it was actually more in 2020 with around 323, and then 217 in 2023. So actually, if you look at all this, Gauteng is actually quite leading pertaining to the number of maternal deaths per province. Could be because of the fact that we are highly populated, Gauteng, and probably more mothers. We see more mothers as compared to the other facilities in the other institutions. But it's just to flag that currently in Gauteng, where you are currently working in George Mokari, we probably could have contributed to that 217. So with that being said, looking at the primary obstetric cause of maternal deaths in 2023, this one is uncorrected, as I said, so probably they could have found more other situations. So pregnancy-related sepsis was around 4.9%. Obstetric hemorrhage was about 16.2%. Non-pregnancy related infections sitting at 17.1. It's still the leading. And then if you're looking at these stats, medical and surgical disorders was sitting at about 16.9, and then hypertensive disorders was sitting at about 16.5. Embolism, acute collapse, unknown, miscellaneous was like 1.0. Pregnancy-related sepsis was sitting at about 4.9. That is your septic miscarriages, etc. And then miscarriages sitting at about 4.8. These are the indirect, meaning indirect correlated to the obstetric problem, which means that indirect, these patients probably suffered from surgical or medical conditions, and obstetrics did not actually, or the pregnancy did not actually directly link or directly cause that death. It might have been an aggravation of that maternal morbidity, or rather maternal comorbidity that actually led to the death, but obstetrics, or rather the pregnancy itself, obstetric care, had nothing to do with the death, meaning it is indirect in that proportion. But to actually just alarm, obstetric hemorrhage was actually sitting at about 16.2. Hypertensive disorders was sitting at 16.5. So directly from this, we can actually even determine the top three to say actually 17.1 was non-pregnancy related infections, followed by medical surgical conditions sitting at 16.9, followed by hypertensive disorders, and then obstetric hemorrhage. Just to actually give you a brief, but remember, as I said, this one is uncorrected. There is a table that actually has the corrected statistics. Like the 4 pillars in HIV, what are we saying about prevention of obstetric hemorrhage? Anemia. Anemia predisposes the patients to obstetric hemorrhage, especially PPH, because iron in itself is needed in the production, or rather is part of hemoglobin. Hemoglobin, there's a heme component and there's an iron component. And you know very well, hemoglobin actually carries oxygen all around the body. So if you are anemic, you are more prone to postpartum hemorrhage, because the oxygen that is actually required, that is carried by the red blood cells in the body, is required in the muscle contraction that is needed for smooth muscles. Because if you don't have oxygen in your body, then that reaction that occurs in the myometrial muscle is not going to occur, leading to a tonic uterus. So how does anemia actually cause postpartum hemorrhage? It's because of the fact that oxygen is needed by the body to actually to actually function and actually carry out its normal physiological processes, like, for example, uterine contraction. So in the absence of oxygen, your myosin light chain kinase is actually needed in the contraction of smooth muscles. If you remember, your myosin light chain kinase in the actin myosin cross bridging, where there's a release of ATP, and then ATP is then converted. So that whole situation is actually oxygen dependent. If you don't have oxygen, that muscle contraction, myosin light chain kinase enzyme or protein is actually needed in the cross bridging of actin and myosin. Then you're going to have an atonic uterus because muscle contraction is actually compromised. So iron supplementation is actually important to prevent anemia. It's very important that you also anticipate and actually be prepared. Where's your oxytocin? Where is your egometrin? Where is your cytotec when a patient is actually undergoing PPH? And also, you must determine women at risk and deliver deliver the referral hospital if you are at the clinic. What patients are at risk? Those who have fibroids will have an atonic uterus. Those who have an abruptio will definitely have an atonic uterus. Those patients who have a big baby will have an atonic uterus. Multiple gestations. Those who have anemia will actually also, those are the patients that you will actually anticipate that here I will actually get hemorrhage. Number 3, availability of supplies, oxytocin, misoprostol. Where is your you must actually also get your Elavi, and you must also get your blood transfusion services ready. And then you must prevent prolonged labor. Look at the pathogram, because patients with prolonged labor are predisposed to a tonic uterus towards the end. A very long prolonged labor may actually lead to muscle atony. And active management of the 3rd stage of labor. So if you if delivery of the placenta, give your oxytocin after delivery of the arm, after the delivery of the head, active management of the 3rd stage of labor, that is it, and routine postpartum or post-cesarean section monitoring of vital signs. And you look at the warning signs as well, that this patient is post-Caesar. What is actually happening? Are the vitals actually well controlled? What is the tachycardia? Is the patient now having increased respiratory rate? So is the patient now also still bleeding intra-op? Let's actually go back from recovery and actually just check if our corners are actually intact. So now when you talk about prevention of PPH, these are the things that you need to highlight, just like we've actually spoken about prevention of mother-to-child transmission, where you actually need to highlight certain things. So these are the things that you need to actually talk about when you prevent PPH or when you prevent hemorrhage. Routine iron supplementation, as I've explained in terms of anemia, you need to anticipate it and be prepared by looking at the risk of the patient. And then also your availability of all these things, your cannulas, your oxytotics, your misoprostol, to aid in the uterine contraction pertaining to a patient who has atonic uterus, prevent the prolonged labor using the patogram, and also looking at if there is any prolonged labor, active management of the third stage of labor, and routine postpartum and post-cesarean monitoring after the Caesar and recovery to see if the patient is doing well. So hemorrhage is often not recognized because blood loss is actually underestimated, because in pregnancy, signs of hypovolemia actually do not show until losses are very, very large. So mother can actually lose up to 2 liters before showing the clinical signs of hypovolemia. So you need to actually know the signs of this hemorrhage. The patient will be confused, will be pale, there'll be a tachycardia. The reduced blood pressure is actually a late sign, which is actually now jumping back to what we're saying, that blood loss actually will only be determined at a later stage, because people are just waiting for the hypotension. But tachycardia is actually quite a sensitive sign pertaining to hemorrhage signs, a reduced urine output, and also fetal heart rate abnormalities in terms of a patient who has an abruptio. When you actually do an NST in a live baby, you can see that, okay, there are decelerations. Oh, the fetal heart rate is actually now going to less than 100 because the baby is now compromised because of an abruptio, or obvious, or there can actually be hidden bleeding. The hidden bleeding may be seen also again in abruptio, where you are palpating the uterus. Abruptio is actually a clinical examination finding rather than an ultrasonographical finding, because sometimes when you look at the retroplacental clot, some people may actually miss it, because clots, once they are actually well architectured, they may actually just look like the placenta when you're looking at the ultrasound, because they may also appear as hypoechoic lesions, or let me not call them lesions. Oh my God, oncology. So they will look like hypoechoic structures on ultrasound. So that is why now abruptio is more of a clinical diagnosis than a ultrasonographical diagnosis, because well circumscribed clots may be missed, and people might actually think that this is a placenta. So when the signs are there, they are significant. So you must not ignore them. You must actually act quickly. Very important when a patient is actually now coming in with APH or PPH, you call a CAP. So you start off with the circulation, IV access by 2 large bore cannulas. You send off blood samples. So as you're putting on the IV line, you then say, okay, I'm then going to take FBC UNE, and I'm also going to take INR and fibrinogen and cross-match the patient and order 2 units of blood. And then you give IV fluids and blood if available. You catheterize the patient and you monitor the urine output, because remember we said that signs of hemorrhage will also be reduced urine output. So it's very important that you catheterize and you monitor the urine output. A patient who's bleeding may actually have acute kidney injury because of the reduced blood supply, because the blood is actually going out of the body somewhere. So meaning the kidneys will actually be compromised in that regard. So you need to monitor that urine output, and then be aware of potential coagulation disorders. That's why I said to you guys, you also do an INR and you also do a fibrinogen. A fibrinogen is also a marker of how much of the clotting profiles have actually been exhausted. Also, your platelets will actually be a marker to actually say, oh, okay, let me now check and look to see if it's an abruptio, being a consumptive coagulopathy. Starts off with the platelets, and then after that, it then continues by taking away most of your clotting profiles. So the blood volume demonstration. I'm going to play a video now. And then this is a video just how you guys should learn how to actually estimate blood loss during a normal vaginal delivery. We don't have this in George Mukhari, but I actually feel like it's something that you guys can actually look at. So I think someone can just mention to me if they can hear the video, just by interjecting to say, yeah, we can hear it, and then we can just listen to how you actually estimate blood loss.
Or lose more than 1,000 mils of blood. The second thing to remember about quantified blood loss
It's
is
audible,
we hear?
doctor.
Perfect, thanks.
a measured or volume component that comes from the under buttocks drape, and the second is a mass or a weight component that comes from weighing any sponge have a hemorrhage or lose more than 1,000 mils of blood. The second thing to remember about quantified blood loss is that it has two components. The first is a measured or volume component that comes from the under buttocks drape, and the second is a mass or a weight component that comes from weighing any sponges that are blood soaked after the delivery. So now we're going to turn our attention to the delivery and the patient's bed. Most of the blood loss in a delivery occurs after delivery of the baby and after delivery of the placenta. So before delivery of the baby, any fluid volume that you have in the bag might be from other sources, such as urine or amniotic fluid volume. In this case, let's say I did a urinary catheterization on the patient prior to pushing. So we have some urine in the bag. Here we have approximately 100 mils of urine in the bag that we're going to want to subtract off at the end of the case when we calculate our total quantified blood loss. Now let's turn our attention to the delivery. So quantified blood loss is really something that Becky and I need to calculate as a team. So I want to be sure she knows how much volume I have in the bag. Becky, there's 100 mils of urine in the bag. Would you just remind me at the end of the case to subtract it off? Sure. Great. Now we'll go ahead and do our delivery. I'll clamp and cut the cord and hand baby off. At this point, we've lost some additional fluid with the baby, mostly amniotic fluid. So I'll want to check the bag again. And I can see in the bag this time that we have just a little over 250 mils. Becky, would you please remind me at the end of the case to subtract off now 250 mils of fluid? Sure, you know, write that down as well, 250. Then I'm going to go ahead and finish the rest of my case. Deliver the placenta. Repair any perineal lacerations I have and manage any hemorrhage. Once the patient's stable, her bleeding is done, then we're ready to calculate our final quantified blood loss. Steve, would this be a good time for us to do our quantified blood loss calculation? Sure. Okay, so I'm going to look at the total volume that we now have in the bag. And it looks like we're just under 750 mils. Vicky, would you remind me how much other fluid volume we were going to subtract off? 250. So 750 minus 250 gives us a quantified blood loss in the bag of 500 mils. So our quantified blood loss from a volume perspective will be 500 mils. Now we're going to move on to the weight or the measurement portion of our blood loss. Now Becky and I will go ahead and calculate our blood loss that comes from our weight or mass from our soak sponges. Every unit should have a list of dry items posted on or near the scale so that you can know and can calculate the dry weight of the things that you weigh. In this case, we know that our lap sponges weigh 20 grams each, and we have 5 sponges for a total dry weight of 100 grams. Now, Becky's going to go ahead and put it on the scale and help us determine our wet weight. So before I place anything on the scale, I'm going to make sure that the scale is zeroed. It is. It looks like the total weight is 233. Again, knowing that 1 gram equals 1 mil of blood loss. We're going to take 233 minus the 100 of the dry weights for a total of 133 mils. Right, so then we'll take our calculated weight and add it to our volume from the under buttocks drape. So we had 500 mils in the under buttocks drape, right, Becky? And 133 here. So our total quantified blood loss for this case is 633 mils. For most patients, if they're uncomplicated, you're going to want to continue your quantified blood loss for the immediate postpartum period, approximately 2 to 4 hours. But for patients who have a hemorrhage and lose more than 1,000 mils of blood, you're going to want to continue the quantified blood loss for a prolonged period of time until they're stable. Therefore, we recommend that you train your labor and delivery staff and your postpartum staff in how to continue to do weights so they can give a quantified blood loss.
Any questions on that? I'm listening. Can we continue? Any questions? Kinelwe?
No, we don't have any questions, doctor.
Oh, okay. So antepartum hemorrhage is actually caused by either abruptio placenta, placenta previa, or APH of unknown origin. So if a patient comes into you with a history of PV bleeding, you will not say to the patient, PV now, mama, you are not bleeding. Or I don't see this evidence of bleeding. You always need to believe the patient that they did have an amount of PV bleeding or any type of PV bleeding. That's why the patient actually came to George Bukhari. So it's important now, as much as you find the PV or the vagina being dry, or when you pass the speculum and then you do see that the patient is actually not bleeding, then in that regard, you can then say the patient is APH of unknown origin. So when you're passing a speculum, what you are actually looking for is, number one, a complete examination of the vaginal tract, because some patient might actually have been sexually assaulted. So you may actually find that the patient is actually bleeding from either the lateral or the anterior posterior vaginal wall, or actually the patient actually may actually be bleeding from the cervix itself or through the cervix. So now you might actually think of an abruptio or placenta previa, of which in that regard you do a clinical examination to exclude abruptio, or you actually then do an ultrasound to actually situate the placenta. Not only that, you also need to check if the baby is alive. Then an APH of unknown origin is when you pass a speculum and you've excluded the clinical assessment for an abruptio placenta, and you've also excluded placenta previa. Not only that, you are also looking at a strawberry, sort of like a cervix that is swollen with sort of like a strawberry like pattern on it. That is a diagnosis of cervicitis. You can treat that patient with flagyl and amoxil, because that is usually caused by an infection. So APH of unknown origin, or your differential diagnosis could be a cervicitis. Your differential diagnosis could also be trauma in the vagina. Your differential diagnosis could be an abruptio placenta. Your differential diagnosis could be a placenta previa. Patient with antepartum hemorrhage, your differentials will include, number one, most common abruptio placenta. Number two, placenta previa. Number three could be APH of unknown origin. Number four, it could actually be trauma from vaginal lacerations, etc. Or number five, it could actually be a cervicitis. So going to placental abruptio, it's a clinical diagnosis. Tender, tense, enlarged uterus. So by that, it's very important when you're doing your clinical exam, you also sieve out the important things that will actually support an abruptio. So if you are presenting a patient in high care and say, this mother is an abruptio placenta, or a 32-year-old female diagnosed with abruptio placenta, as confirmed by the following signs, or clinical history, or clinical signs and symptoms. So when you're presenting a case in high care of an abruptio placenta, I have a 32-year-old female, currently para 1, grav 2, or maybe the patient would have delivered. So this is how you then phrase your presentation to actually sound like a senior. 32-year-old, now para 2, currently in high care with the diagnosis of abruptio placenta, with the following, or rather you can say as evidenced by the following. On history, patient came in with APH, reported a gush of blood coming through the vagina. On arrival, the patient was hypotensive with a tachycardia, and the abruptio placenta was clinically diagnosed with the following signs: a tender enlarged uterus, and then BPs were like this. And then upon ultrasound examination, we found that the baby is alive or the baby is dead. If the baby is alive, she's currently 6 hours post-cesarean section with a confirmed abruptio in theater. Currently, her vitals are like this. Currently, the HB is that. Currently, the platelets are this. This is how now you will actually now communicate with the examiner that actually I know what I'm talking about. Not these things that we actually hear you guys presenting in high care. This is a 32-year-old para 2. currently in high care with a diagnosis of an abruptio placenta. She's 6 hours post-cesarean delivery for an abruptio placenta with an alive baby, estimated birth weight of 2.7 grams. She came in with the following signs and symptoms: a history of PV bleeding, no history of trauma. On examination, a post-speculum was passed, and we found that she had bleeding, or rather blood coming through the cervical os. In addition to that, this patient had signs of hypotension with a BP of about 86/37, and she was aggressively managed with fluids and transfused the following blood products. In addition, we did an ultrasound and confirmed that the baby is alive. The baby then was rushed to theater, or the mother was rushed to theater with an estimated blood loss at theater of about 1,000 mils. She was managed and transfused 2 units of blood of peg red cells, or 4 units of peg red cells and FFPs. And at this current moment, she's currently stable. BPs are sitting at this. The current HB and platelet is this. Now, this is how you then bring forward to the examiner that you actually understand what you are talking about. You talk about the shock, you talk about the tachycardia. Not only that, when you are explaining to the examiner that this patient is here, but however, this is what we were expecting. As I said to you, a patient who's bleeding will actually have reduced urine output. This is something that you also need to put in your clinical exam, in your clinical presentation. And also, this is something that you also need to actually say that this is the input, this is the output, and this is also the current urea and creat. Does it make sense, Ndwandwe?
Yes, Doc. It makes yes, it makes sense.
Not these dry presentations that you guys hand over to us, and I'm like, what is the student actually saying? Diale, does it make sense?
Yes, it makes sense, Doc.
Tebogo, does it make sense?
Yes, doctor, it does.
So now, why are we hearing these dry presentations, Tebogo, when you guys are handing over?
Ish, doc, I'm not entirely sure.
But you do agree that they are dry.
There's room for improvement, doctor. As we have more of these tutorials, see, hopefully we
I
will
know,
improve.
Tebogo, but you do agree they are dry, was the question.
Partially.
Let us continue. So the management of abruptio placenta, a live baby, of course, live baby, you then manage the patient, you resuscitate the mother. As soon as the mother is stable, you deliver. Because during that time, the abruptio, a rule of thumb, not really based on studies, but based on just clinical expertise, they say that if the blood loss is more than 1,000 mils while the baby is still in utero, that will then cause the baby to actually have an IUFD. So you need about 1,000 mils of blood loss for the baby now to become an IUFD. So that's why now you need to act in a mother who is actually now having an abruptio with an alive baby, because once that blood loss actually goes to 1,000 mils or more, it has been said that that will then lead to an IUFD. But however, for a baby that is dead, you need to actually resuscitate the mother and induce the labor by rupture of membranes. You will only rupture membranes only if the blood products are available. Why are you rupturing Why would you rupture membranes only when the blood products are available? Because the seal of this rupture of membranes may actually be keeping some of the blood inside the uterus. So once you rupture that membranes, you may actually have a surprise of a pool of blood that actually comes in. And it's very important that you have the blood products ready and resuscitate the mother to actually match the losses that you would have actually quantified when the rupture of membranes was actually started, or rather initiated. Now, when it comes to placenta previa, it's a condition in which the placenta lies very low it actually covers the presenting part, or a portion of it covers, or rather a tip of it covers the presenting part. Is the most common symptom of placental previa is that it's a painless vaginal bleeding as compared to an abruptio, where it is actually painful vaginal bleeding that is also accompanied by aggressive uterine contractions. So placenta previa, always you must understand that you deliver the patient at 37 weeks via a cesarean section. But however, indications for Caesar for a placenta previa will then include, number one, if the mother is actively bleeding and the bleeding does not subside, or if the patient is actually in labor. Those are the only two indications for a placenta previa. When you then furthermore, after stabilizing the mother who's actually bleeding, when you do an NST, then you see that there's signs of fetal distress. That will also be an additional indication. Why would you send a mother who has a placenta previa to theater? All the other APHs must actually undergo an ultrasound to exclude placenta previa. And placenta previa must be discussed with the senior. It is very essential that the most senior surgeon actually performs this surgery, and it's advisable to have some form of tamponade available at the surgery. So you actually in either a balloon catheter or something that is called an Elave that we'll probably discuss later. So postpartum hemorrhage will actually happen in patients. As I said initially, you must identify those with risk factors. So when would you actually anticipate postpartum hemorrhage? In conditions like a patient with a pre-prom. Pre-prom actually predisposes the patient to uterine atony. Number two, patient with fibroid uterus will predispose the patient to atony. Number three, patient with a macrosomia will predispose the patient to a uterine atony. And I'm always mentioning uterine atony because it's the most common cause of postpartum hemorrhage. Another thing that will also predispose the patient to a uterine atony will include multiple gestations as well. So in terms of postpartum hemorrhage, as I said, you must always anticipate it, because now you are risk stratifying the patient to say, okay, this patient is definitely at risk. Let me check the booking bloods. Oh, an anemia and pregnancy. Let me make sure I actually correct the HB while this patient is in labor, at least to push it up until 10, so that I don't actually get a postpartum hemorrhage. This is a patient with a fibroid uterus. When you're examining the file, that this patient is a fibroid uterus that was diagnosed properly by one of the doctors in ANC to say, oh, this patient is known with a uterine fibroid, so I'm anticipating postpartum hemorrhage. In addition to that, this patient was diagnosed with a pre-prom and stayed in ward 25 for the longest time. Now is said to be in labor. That patient will also be predisposed to uterine atony, as well. A macrosomia as well might actually predispose the patient to uterine atony. So in terms of hemorrhage, as I said, you call a cab. As the circulation, you insert 2 IV lines, you then cross-match, and then also you ask for bloods, FBC, UNE, INR, and also fibrinogen. And then you resuscitate, you control the bleeding, and then you make the diagnosis. Why is this patient now having postpartum hemorrhage? And then you treat it. So once you are there with the patient with postpartum hemorrhage, first thing that you do, you call for help and do a primary survey. You're just looking around for any hazards. The patient is bleeding? Now let's prepare our station. Let's prepare everything. Is it safe to work in that environment? You call for help. You do a primary survey. You call a cab, insert an IV line, as I've mentioned, all the other things. You clear secretions, and then you give the patient oxygen. And then that is the part where you actually do the breathing part. So you call a cab, put the patient in, you call a cab, and then clear secretions, and then you give the patient oxygen. And then, as we said, you insert the IV line, 2 large IV bone needles, at least green, and then you draw bloods, type and screen FBC and coagulation profile, then fibrinogen, and then you must always do a blood gas, and then you monitor the vital signs. What are we looking at? Are we having a tachycardia? What are the SATs? Because remember, you've already covered the fact that you're going to do a CAB, which is B for breathing. You look at the SATs, you look at the BP, and you also look at the tachycardia as well. Then after that, you start IV fluids. Ringer's lactate on one side. The Ringer's lactate must actually have 20 units of oxytocin on the other line. And then you immediately rub the uterus and you do bimanual palpation. While you are doing that, you reassess. vitals, and also if the uterus is contracted. It's very important that you actually reassess your vitals. Your blood pressures, is it fine? And also, again, is there tachycardia? And also, what are the SATs on oxygen and what are the SATs on room A? So you assess the placenta that was delivered. After you've reassessed, as I said, first thing that you do, you call a cab, circulation, bloods, cross-match. If the urinary catheter is not in, you insert urinary catheter. Then on one line, Ringer's lactate, 20 units of oxytocin, you run that. And then you rub the uterus. One of the team members is going to assess to see if the placenta is complete or not. Then after that, you do a PV, you expel the clots, and you continue with the oxytocin infusion. Each and every step here needs reassessment. What are you reassessing? Is the uterus contracted? And you reassess your vitals. First line, you're going to start off with, already oxytocin is running. Then after reassessment, your next line will be agometrine, 0.5 milligrams IMI stat, or you can give symptometrin, which is 1 amp. After that, you reassess. What are you reassessing? You are reassessing if the uterus is well contracted and if your agometrine and symptometrin is working, and you also reassess your vitals during that time. Someone also is at the lab trying to get those bloods ready, and then someone else is at the lab trying to find out what is the HB, and someone will actually also be coming with the gas. Gas is very important. How's the metabolic status of the patient? Because remember, this patient is bleeding, so tissues are not well perfused. So you are going to get something like a metabolic acidosis with a high lactate. Lactate is a marker of tissue perfusion. So if the lactate is more than 1, you are actually in trouble. It means that this patient is bleeding and the liver, the kidney, and all the other things are not well perfused. So now you are reassessing. You are reassessing what? The first step, if agometrine and symptometrin have been given, and also reassessing if they actually are working. Then after that, you reassess, you repeat the above at least once. So you go back again to agometrine, or you give symptometrin 1 amp. If now that doesn't work, misoprostol is not really proven in this regard, but you give about 800 milligrams to 1,000 micrograms. Some people just give it with the ease of saying that I know it works in terms of induction and inducing labor and uterine contractions. So why not give it in terms of PPH? So some people have proven that misoprostol is not really a good drug to actually give because it doesn't actually contract the uterus quite well as it is used for induction of labor. But however, some people just use it just to actually say that if it's proven to induce contractions, why can't I then use it also in? So some people use it, some people do not use it, but I recommend that you do use it. After you've done that, you reassess again. What are you reassessing? The patient is the patient continuing to bleed? Is the uterus well contracted? And then you are also looking at the vital signs, because now you need to start blood transfusion. If the patient is now hypotensive and continues to be tachycardic, you need to start your blood transfusion, looking at the blood gas as well, because remember, the tissues are not being well perfused, so you need blood to perfuse them. Once all those steps you've covered, you reassess again by giving tranexamic acid, 1 gram IVI to control the bleeding. And then tranexamic acid can be repeated again for the second dose. If you've reassessed, the next drug that you have is prostaglandin F2 alpha, which you can give 1 milligram intramyometrally. But this is not available, so you can skip the step, but you can mention it in the exam that you can do, you can give prostaglandin F2 alpha. Very important that you actually mention the reassessment on each and every step. You are reassess if the patient continues to bleed, and then now you've already given 2 doses of cyclopentone, 1 gram, and then you can give another gram. However, if the patient now continues to bleed, you consent the patient for examination under anesthesia, plus minus tear repair, plus minus hysterectomy. When you are rubbing the uterus and you're expelling the clots, you will then already have a diagnosis before we actually send the patient to theater. Either the diagnosis will be retained products because you've examined the placenta, and you see that there are retained products because the placenta is not complete, or digitally you felt that there are products that are actually there. With that being said, some of the other steps are not really then that important because already you have given the ergometrin or you've given the scintimetrin, but you already have a diagnosis to say this patient now is having a retained products. We need to take the patient to theater and remove them. There is still space for most of these steps because if the patient continues to bleed, you need to make sure you stop the bleeding up until you get to theater. So there is a space for some of these steps. But however, while you already have a diagnosis and you are continuing with these steps and you are reassessing, because remember, reassessment is not only the vitals, but to check if the patient continues to bleed. And in addition to that, to actually have a diagnosis to say, oh, this patient is actually bleeding from a vaginal tear. This part also applies to all because the consent for examination under anesthesia, and then you're going to do a tear repair, plus minus tear repair, or plus minus hysterectomy, because a tear repair, if the patient is uncooperative and the patient is restless because of this continued blood loss, theater is the best setting in terms of clinical studies that showed that patients, you will be able to control the bleeding of any cause in theater. Why? Number one, if a patient has retained placenta, you need to use a curettage in theater and you need the patient to be perfectly stable. Number two, also, if a patient now has a cervical tear, you will only be able to suture that in a very controlled setting. And also if the patient is not actually restless, because now with the patient with continued bleeding, you may actually have the GCS actually even go down. The patient may be restless, the patient may be uncooperative. So get your consent and then the patient can actually go to theater. What are you going to do in theater? You're going to do either a tear repair. So once the patient is under anesthesia, you're looking at the anterior wall, you're going to look at the posterior wall, and then you repair the tear repair. You've done an ultrasound already, or you felt the products digitally. And if you feel like, this patient is just for evac, after you've assessed the tears, you repair them, you also do an evac. And then if the patient is not bleeding anymore, you stop, the patient then goes to postnatal ward. But if the patient actually continues to bleed, you can insert a balloon tamponade in there so that you actually constrict, or rather press against the blood vessels that are literally still oozing after the removal of the placenta or after the removal of your curettage. You can use a blood balloon tamponade to actually tamponade against the vessels inside the uterus in the endomyometrial layer. So if the patient continues to bleed, remove the balloon tamponade. Now put the patient out of the lithotomy pose, because this patient, remember, is on lithotomy position in theater. Remove the balloon tamponade because now you can open the patient laparotomy and then try and do a B-Lynch or hemostatic sutures where you fold the uterus and then now you're trying to compress the uterus against itself so that it actually stops bleeding. If the B-Lynch doesn't work, you can do a stepwise uterine devascularization where you now tie off the uterine artery, you go off into the ovarian arteries, and then you can even go as far as the internal iliac. Then the last step now, if the stepwise uterine devascularization doesn't work, after you've tried the balloon tamponade, it's not working. If the balloon tamponade is not working, you continue open laparotomy for a B-Lynch. If the B-Lynch doesn't work, you do a stepwise devascularization. If that doesn't work, then you do a subtotal hysterectomy where you leave the cervix, but you remove the portion of the uterus. So uterine atony, you massage the uterus, you give the oxytotics, as I've mentioned, oxytocin infusion, ergometrin, and the prostaglandin F2 alpha. You've already put up the urinary catheter, so that's fine. You can actually do a aortic compression. If the patient continues to bleed, you pack the patient with swabs, and then you can actually press against the uterus to press against the aorta, because some of the vessels that are actually, the aortic compression will actually now temporarily stop the bleeding. And then ongoing bleeding, you actually look for other causes. You do a uterine tamponade, or you do a examination under anesthesia and or laparotomy. During this time, you do not delay. Aortic compression, you can replace that with actually, you can just say, instead of actually packing the uterus with the swabs, you can literally do a bimanual compression where you put one of your fingers, you put your hand in the vagina, and then also you put your other hand suprapubically where you feel for the fundus of the uterus, while you are now doing a temporizing measure. Meaning a temporizing measure is when the patient continues to bleed and you are trying to stop the bleeding via bimanual compression up until the patient goes to theater, while the other team members are organizing anesthesia. The surgeon is organizing themselves to understand where could this bleeding be coming from. So the bimanual compression is sort of like a temporizing measure up until you actually get to theater so that you can actually solve the problem. The oxytocic agents that we're actually talking about here is the oxytocin. Some people can give 20 units, some can actually give 40 units. So you can even give 40 units on that 1 liter that's running on the side as you are doing a bimanual propagation. This is the ergometrin that we're talking about, that you actually give a total dose of 1 gram or 1 amp. So IMI 0.5 grams, and you can repeat the dose after 15 minutes. That's the step I was actually reflecting about here, that you can repeat at least once the ergometrin. So after 15 minutes, after you've given odometrin, you reassess again after 15 minutes to see if the patient is still bleeding. And then if the ergometrin is actually working, you still have another 15 minutes to give another dose of ergometrin for a total dose of 1 milligram, but you don't use it in terms of hypertensive preeclampsia or hypertensive patients. Also symptometrin okay as well. There as well, it is in labor ward, which is a combination of ergometrin and 5 units of oxytocin. You give 1 amp. There is a space for you to repeat it as well, but you don't give it hypertension and also preeclampsia and those with heart disease. So some people err in the side of caution to say, I've already given max dose of oxytocin by 40. So if you've given 40 international units of oxytocin, but however, if you've given 20, you still have space for you to repeat the ergometrin, because the 5 units of oxytocin that is there added to the 20, if 5 times 2 will be added, will give you 30. But if you're already given the 40 units, you can err in the side of caution not to actually repeat the symptometrin, because now you are over the max dose of oxytocin, now meaning 40. So if you have chosen 20 as an infusion, there is space for you to actually give the symptometrin again, knowing that is a combination of 5 units of oxytocin, then 5 plus 5 is 10, adding to the 20 is 30. And you did not actually now go over the 40 international unit dose. Misoprostol, you can give it parectally. Remove this dose. It's actually now 800 to about 1,000 grams. So it's some say 400 to 600, but just give about 800 to 1,000 micrograms. It causes diarrhea. It can also cause pyrexia. So if a patient, now this is the larvae I was actually talking about. Let's actually watch this video and then we can wrap up this presentation. So that's how the Elavi works, and it is available in labor ward, and this is how it actually works and how you insert it. So if it's a retained placenta, it should be ideally removed under anesthesia in theater. If not possible, or the patient is bleeding heavily, you can try and remove it in labor ward with a bit of analgesia. So you can do the manual removal in labor ward, because a patient with a retained placenta in theater, a patient with retained placenta will always have an issue of bleeding. So if the bleeding actually continues and you don't want to be waiting for theater and you can scoop it out, you may do that. It is painful, but give the patient some analgesia at least to relax during that that procedure. So retained placenta products, as I said, you should remove them under anesthesia. You must actually first explore the uterus manually, and then please beware of perforation of the instrument use. And if needed, you can curettage with a largest curette available, and then uterine contraction will then ensue, meaning that the uterus is actually now empty. During that time, you will definitely know that the patient is now contracted, and you can even ask the anesthetist to actually give oxytocin infusion while you are actually doing the curettage, so that maximal contraction can actually be achieved. Examine the cervix stepwise as well. As I said, examination under anesthesia, not only are you actually looking at the vaginal walls, anterior, posterior, and also the lateral walls, but you're actually looking at the perineum as well. Did the patient have an episiotomy? Was the patient now having, what is this again? An OASIS, which is obstetric anal sphincter injuries. So you check if there's a perineal tear, or you check if there's now affectation of the perineal skin. Not only that, are the perineal muscles also torn? You repair them. Is the internal, external, and external sphincter also the bleeding, that the cause of the bleeding? Then you repair them. You also you repair the anorectal canal if it's actually torn in case of a 3rd-degree tear. You examine the cervix also manually, and you examine the uterus manually as well, from the fundus to the lower segment separately. Then for extensive lacerations, consider actually vaginal packing or balloon tamponade after the procedure, or you can actually give tranexamic acid slowly as an IV injection. As I said, if it's an unknown cause, you need to resort to examination under anesthesia, and then you just look at what is actually going on. As I said, as the patient continues to bleed in labor ward, you will not actually be able to properly examine that uterus or that perineum properly during this time when the patient is bleeding, because the bleeding as well might actually make you not see some of these structures properly. Then post-op, half hourly. First 2 hours you do observations half hourly, and then in the next 4 hours you do observations every 2 hours, and then 4 hourly in the ward. And then observations actually need to be recorded. Pad checks when you're checking for vaginal bleeding, urine output, and also the temperature, blood pressure, and also pulse rate. Please, it's very important that you actually put the patient, at least, because now you've been manipulating and working on the cervix and also vagina, you also putting these foreign objects. So maximally cover the patient on antibiotics. We traditionally use Augmentin 1 gram, Augmentin 1.2 gram IVI 8 hourly, and we also give Flagyl 500 milligrams IVI 8 hourly to cover all the bacteria that you find in the cervix that you are probably going to reintroduce in the uterus when you're inserting things like the Elavi, or when you're working with instrumentation like the curettage. So now this is just something about temporizing measures when you're transferring unstable patients from a district hospital to like a tertiary hospital like George Mukhari. You can use a uterine tamponade, a uterine tourniquet with the Foley's catheter, or non-pneumatic anti-shock compressions, or you can actually just tie, if you have a problem with achieving hemostasis, you can actually tie the uterus using a catheter, Foley's catheter, where you're now compressing on the uterine vessels so that the patient actually does not continue to bleed. Now, recap: recognize the obstetric hemorrhage and what are the causes, the CAB protocol, blood replacement and the diagnosis of the cause of bleeding, and then the methods to arrest the hemorrhage, looking at all these things we've spoken about. We spoke about ogometrin, we also spoke about symptometrin, and also repeating them, doing the giving the oxytocin 20 international units in 1 liter so that you can aid in uterine contractions. And then this is one of the uterine compression sutures, which is a B-Lynch that you can actually do in theater with the uterine incision that you have already completed and you are done, but the patient continues to bleed. You put 1 incision below, you come out at the top, and then you go around with that suture at the back, and then you do a lateral bite, and then you go to the other side, then you go up again with the suture coming from the top to the bottom, while your assistant actually folds the uterus, then you tie in this position. This one is sort of like a modified B-Lynch, so it's like another type of B-Lynch where you just put 1 towards the front, and then you come out at the back and you tie at the top, and then 1 at the front, come out to the back, you tie at the top. So if you examine the cervix using stepwise clamps, and then you explore the uterus manually, you must always repair under good lighting. That is why it is actually important that you do it in theater. And then if you suspect a uterine rupture, that patient is definitely high risk. There's a patient who's a previous Caesar ×1 and you're allowing labor to progress. So early resources to theater and the senior assistants is very important, where you now need to do examination under anesthesia during the laparotomy. You repair the tears. You either do a subtotal hysterectomy or total hysterectomy if you cannot fix the uterine rupture, or you tie a catheter tightly around the lower uterine part of the uterus, and then you refer if you are in another setting. So hemorrhage, compression of the aorta is one of the temporizing measure. Uterine compression using a B-Lynch, uterine vessel ligation, as I've reflected before, which is a stepwise uterine revascularization, and then hysterectomy. Any questions pertaining to APH and PPH? Inelwe, any question?
No, doctor.
Ramarumo, any question?
No questions from my side, doctor.
Ndwandwe?
Yes, Doc. No question, Doc. It was well detailed, and yeah, it was followable, like in terms of the steps and the flow diagrams and those videos they aided in how we can see these things in real life. So, thank you for that, Doc. No questions.
Tebogo? Tabiso, any question? So I'm on call tomorrow, and then probably we can do fibroids and CA cervix. But yes, Ramarumo?
So, Doc, can you please share the slides?
Asunghlanyisa. What are you going to do with the slides? Didn't you make notes, is the question?
So, I was trying to listen more than taking notes.
Or you tend to listen more than taking notes. Okay, no, it's fine. It's fine. Any other question? Okay, so we're gonna cover fibroids and also CA cervix on Saturday when I'm post-call. I will text you guys 30 minutes before. With that being said, do not ever think for one moment, Chawuke, Diale.
Doc, on Saturday we are on call.
Is anyone on call?
Oh,
What is
sizwa
how?
attenda kanjani?
You attend a lot. You're gonna make a plan.
Asina
Chawuke,
data,
are you
how?
not gonna make a plan? How will you make a plan? So, okay, when are you suggesting that we do the tutorial then?
Doc,
Don't you
isn't
guys
it
suggest?
initially you had suggested maybe Sunday at night when you are on
I
call?
know. You are aware that I'm doing gynae oncology now. I'm no longer doing obstetrics.
I understand.
Yes, I'm listening. I'm listening to suggestions. Then I'll wait on you guys to actually just come up with Sunday. It's very tight because Sunday I'm actually on call. I'm doing Friday and Sunday. So it's gonna be tight on my side, but I think we'll make a plan and see when can we actually see. But it's important that it is important that I take more, especially the final years, especially with CA Civics, because next week they are coming to Msibi, and there's a lot of things that are happening in that ward round that I probably need to protect them from, because a lot has been happening with the previous units. It has been very traumatic. Any other issues? Okay, in the absence of questions, we can all now go sleep and attend to the notifications we've been getting that actually it's time to sleep now. Study hard, all the best, and then all the other additional tutorials, I will actually just say when I can actually do them. I will probably send a notification 30 minutes before so that we don't have people that are actually coming in late to the tutorial because they have connection issues. So with that being said, you all should have a good night.
Thank you very much, Doctor. Good
Cool,
night.
bye.
Thank you, Dr.